All right, good afternoon, everyone, and welcome. My name is Catherine Kosin, and I am the Volunteer and Membership Program Manager at Chevy Chase at Home. For those who are not familiar with us, Chevy Chase at Home is part of the nationwide Village movement, in which neighbors get together to help their neighbors, seniors, age in place. So we help seniors in the Chevy Chase area with volunteer services like rides to medical appointments, tech help, friendly visits, changing a light bulb, all of that kind of stuff. And we also have social events, clubs, and educational programs like this one. To learn more about us and other educational programs that are open to the general public, please go to www.chevychaseathome.org. We are so glad that you could join us for the 5th installment of our Navigating Life's Journey series, in which you learn how to navigate your options for each stage of aging. Each program takes place on the first Friday of the month at 1 p.m. And in today's session, our fantastic panelists will examine assisted living options, including those with memory support, and discuss how you can pick the right place for you if you're considering this step. I now want to introduce my co-host and partner in this series, Angelique Jackson, who will be co-moderating the event today. Angelique Jackson, LPN, is the Manager of Marketing and Business Development at Charles E. Smith Life Communities. She has been a nurse for over 16 years, serving in the areas of post-acute and hospice care. I also want to briefly introduce all of our panelists today, beginning with our other partner in this series, Kiersten Parsons, MS, RDN, CDP, who is the Director of Healthcare Sales for Ingleside. Kiersten has worked in senior living for the past 11 years, 4 years of which have been with Ingleside. Most recently, Kiersten served as the Independent Living Administrator for Ingleside at Rock Creek. Kiersten started her career in long-term care nursing, then pursued further education in human nutrition, working as a clinical dietitian for seniors at all levels of care. Kiersten is committed to excellence in senior living services and is passionate about educating and equipping older adults to lead healthy, wellness-filled lives. And as a clinician and healthcare services professional, Kiersten brings her joy for engaged living and her skill set in healthcare services to the Ingleside sales team, where she focuses on supporting the growth of assisted living and memory care support, assisted living and memory support assisted living neighborhoods in each community. So very on topic for today. Return attendees will recognize her, though, from moderating past panels with Angelique. Next, I also want to introduce Mary Mell, LNHA, who is the Executive Director of Kensington Park. Mary Mell is a true local, born and raised in Silver Spring, Maryland, and she has over 25 years of experience in the healthcare field. Serving older adults has always been her passion, which led her to attain her graduate degree in Health Services Administration in long-term care at the George Washington University. Shortly after completing her degree, Mary served as a licensed nursing home administrator and later received her certification for Director of Assisted Living. For the last 8 years, Mary has been the Executive Director at Kensington Park. Next, I want to introduce Maria Khader, RN, BSN, CM, DN, CDP, and CADDCT. Maria Khader has served as a registered nurse for over 27 years, specializing in the care and advocacy of older adults. Maria is currently certified as a case manager, dementia practitioner, and Alzheimer's disease trainer and speaker. She also holds public health and education certificates from the Johns Hopkins University in Baltimore, Maryland. She established J.K. House of Grace assisted living facilities in 1995, specializing in the most challenging and complex cases of advanced dementia. She is known as the Dementia Whisperer because of the tips she uses to enhance the lives of her residents. Maria's ongoing passion is to see her patients receive the best love and care possible. And last but not least, we have Brenda Rice, LHNA, who is who is the VP of Operations at Charles E. Smith Life Communities. Brenda L. Rice is dedicated to improving long-term care and rehabilitation outcomes. Brenda has over 24 years of experience as a licensed nursing home administrator who consistently transitioned organizations to certified Medicare 5-star ratings. Her early career includes experience in recreational therapy services in acute rehabilitation and in research at the National Institutes of Health. As an experienced executive director and administrator for senior living communities, Brenda has a passion for getting to know all the residents of each community she serves. So, as a reminder, this is being recorded, so please make sure that you are muted except when asking a question, and those questions will all be at the end during the last half hour of the program. You can submit questions in the chat at any time, and we will read them during the Q&A at the end. So, Angelique, I hand it off to you for the first question for our panelists.
Thank you so much, Catherine, for the introductions, and Chevy Chase at Home for giving us the space to have these important conversations. Thank you to everyone who tuned in today, and a special thanks to our panelists for their time and expertise. Each of our panelists represents 4 types of assisted living communities with diverse experience when it comes to delivering care at this level. So my first question for the panel is, what is assisted living? What types of services do assisted living communities offer? And what are the differences in the types of care and services available in each of your communities? Maria, would you please start us off? Maria, you might still be muted.
Thank you so much for having me on this panel, and it's an honor to be with all of you, and especially trying to clarify the questions that you're going to be asking us about assisted living. It's your first question will be, what is an assisted living? An assisted living is it's a way of providing care for people who are having difficulty living at home and living independently, but it does not need the daily nursing services provided in a nursing home. Assisted living, it furnishes the place, the meals, assistance with daily activities, example like the dressing, the meals, the bathing, and the medication management. People live in an assisted living, they have less complicated cases that they can be only assisted by caregivers who are able to provide the care for them that they cannot get it at home. Services, I don't know if anyone wants to add to this. Services that we provide in an assisted living, it can be activities of daily living, as I said, dressing, showering, bathing, toileting. It can be home cooked meals, the 3 meals a day, plus snacks during the day. It can be the medical supervision by whatever orders we get from the doctor, if we want to have like vital signs or any medical supervisions we need to do for them. Activities, providing activities for them. It can be education and support for the residents themselves and for the families. We do the housekeeping, we do the laundry, we do medication administration, and we do the staff. They are on site, they're supervising what things are going on with the residents and what they're doing. We can do also some kind of care, it's called respite care, and the ratio, or we're gonna go back to that in a little bit, but we do also memory care in an assisted living. So these are basically the summary of the services that we provide in an assisted living.
And Maria, it's Mary. Hi, welcome everybody, and thanks for having me here with our colleagues. I just, the different types of assisted living, because Maria, I know you have a smaller group home, correct?
Yes.
So, there's varying sizes of assisted living that you should be aware of. Maria's got a great group home there with her care and assisted living. And then you can get to another level where you have larger assisted livings. And that's what I'm familiar with Kensington Park. As far as level of care, there's, a state level of care requirement that you can get to a level 1, 2, or 3, 3 being the highest level of care, which means you can care for people that have more needs. All assisted living is really based around somebody's physical needs and the emotional pieces too. So if you're at home and you're finding, you may need more assistance with dressing or, walking or transferring, also having some mild cognitive impairment, I think the best way to think about assisted living is just, another living environment where you have all of us here to support the needs that you may be missing at home. And I think, like Maria said, all those services, the housekeeping, the meals, the laundry, those basic services are all there. As you get to different assisted livings, you're finding different types of services. For our community, as an example, nurses are providing medications round the clock. That doesn't necessarily have to happen in assisted living in Maryland, but the community here felt that that was an important piece. We have 3 different levels of memory care versus other types of programming, and some music therapy program that we have on site. Rehab services, most assisted livings do have some of this, but we have physical, occupational, and speech services, as well as like a dietitian. And I know, both Kiersten and Brenda too have similar services. I just wanted to let them have an opportunity to talk as well.
Thank you.
Thank you, Mary, and thank you everyone for inviting us to participate today. It's always I'd rather spend time, I think, on a Zoom than doing the paperwork that's sitting on my desk right now. So thank you guys for inviting us. So at Charles E. Smith, one of the Life Communities here, we're located in Rockville, Maryland. So you've heard about Maria being a smaller group home, Mary being an independent, Kensington Park. So at Charles E. Smith, we're part of a bigger community. So we have the skilled nursing home, we have independent living, and then we have our the memory care units. And we also have then Landau House, which is our assisted living. So different communities and different ALs are in different places. So we're all in, and Kiersten's probably going to talk a little bit more, we're similar in that size. But being able to offer the programs and assisted living at what level the resident is at. So I think the 2 ladies before me kind of gave a great kind of setting for where we're at. So I don't really have too much more to add about what assisted living is, other than we're kind of all different in a little bit of a way.
Yeah, Brenda, I think the only thing I would add to that that's different from what we talked about last month. So of course I have the privilege of being on here every month, right? And knowing what we've already talked about. We've talked about independent living. And so I would just say kind of to have a hook in your mind to hang assisted living on. What does that mean? It's a regulated level of care. And I think that's a really good starting point in the sense that we've talked about independent living, which is first and foremost really a social model. But once we start talking about assisted living, and then next month we'll talk about skilled nursing facilities, these are regulated levels of care, meaning that the local jurisdictions have input and the Center for Medicare and Medicaid Services have input. So in many ways, Brenda, Maria's communities will differ from the Ingleside model, but in some very, very important ways, we're all going to be following the same guidelines for how we provide care, staffing ratio minimums. There's certain guidance that is appropriate for assisted living. So our models for programming might change, and whether we have laundry included or not. I mean, there's things that'll differ from campus to, a group home setting. But I think it's important to understand that once we talk about assisted living, this is a regulated level of care.
Great. Thanks so much, everyone. And thanks for, again, I think this will definitely give our participants a good idea of what's the difference between assisted living and other type and independent and also later types of care like nursing. So next, I want to focus more on memory support. So are there memory support programs in place at all assisted living communities? And within that, are there secured areas specifically for residents requiring memory support? What kind of security protocols are in place? If you could start, Maria, please.
Yes, we support memory care, and actually in our assisted living, we are more well known for the most difficult cases and most hands-on cases with memory care and behavioral issues that related to memory deficit and impairment. So for that reason, we have the other thing I want to add about the assisted living that I am talking about is the intimacy of care. You know, with the different types of assisted living that myself, Mary, and Kiersten and Brenda talked about, the different sizes of that, it gives the resident or our client different kind of relationship with the caregivers that they're providing the care for him or her. So with ours is more intimate because it's a smaller environment, it's more one-on-one. So when we have someone with memory care and has more behavioral issue when in terms like to elopement, wandering, and stuff like this, we're able to have them in this small community and small home environment. And we have secure doors that with alarm system, that's the security system that we have in the facility. Most of all, it's in the neighborhood. The neighbors are working for us, kind of like supporting us. If one of the residents was sitting outside and start wandering, the neighbors will be with us, although we don't leave them outside without attendance. So like when we sit on the porch, one of the caregivers will be with them, one of the caregivers will be inside with the rest of the group that they're not outside. So it's a safe neighborhood. We have a monitored fire alarm system. We have also monitored doors and windows with the alarm system. So if he wants, like the windows are wide enough to be an egress for them, if in case of emergency. So we can use those windows to get them as in case of emergency. So we have the alarm doors, we have the alarm windows, and we also have the monitored sprinkler system. We have also the surveillance cameras in the public areas, in the common areas, which is the hallway, you know, any public areas. Again, you think of a home here, not a larger facility or institution. And we have the standby electric generator in the facility in case of any emergency with the storm or, you know, we lose power. So these are the security system that we have in our small facility.
So kind of to add what Maria is, when you're looking at a memory care support program, every assisted living is not going to have a memory care unit. They may not even have locked doors. So as you're looking for those kind of programs, it's, you know, are you looking for someone who is declining and needing a memory care unit? At Landau House and Cohen Rosen for our organization, Cohen Rosen is an 18 apartment memory care unit, and it is a secured unit with very specific programming for the memory care. We use BCAT, which is a behavioral cognitive assessment tool, and you can go online and actually participate in some of those now. You don't have to be in our organization to do that. It's kind of brain health. So making sure that we're moving people through the right levels of memory care. So we also have connections, which you don't need as much that one-on-one, what Maria was saying, assistance, where you're able to do more activities on your own. So again, when you're looking at communities, each one is going to be a little bit different as to what programs they offer and those size and what those ratios are.
Yeah, I would just add and reiterate to Brenda's point that if you are specifically caring for a loved one with neurocognitive change, then there's kind of a different set of questions you're going to be asking as you are looking at communities or looking at care options. So certainly safety and security is a concern, right? If you've got a very physically able loved one who we call it elopement or wander from the community, you of course want a secured neighborhood. But I think you also want to ask questions that are more targeted towards the programming and therapies for that individual. So just as with any other disease, you want to make a modification to what that individual can participate and benefit from. So more than just a secured neighborhood, what does the programming look like? Is it modified to their needs? How robust is that programming schedule? Does it give them the chance to have a purposeful and engaged day?
And Kiersten, I'd just like to follow up on that. I think your point of that, I think the other component is just assisted living versus someone in memory care. The memory care programming is going to be geared really towards engagement of those residents, keeping those residents throughout the day active. And that's, through activity programming, but it's also through an increased staffing level. You're going to need more staff to then take care of those residents who need that extra, love and attention, and the walks outside and all of those kinds of things. I think that's part of the safety protocol anyway. And then I just think, if you haven't experienced, licensed music therapists are just amazing when managing, an agitation in memory care or frustration or whatever. You can do individual group programming or individual sessions. And that is extremely helpful as an alternative to, looking at medications and things like that for somebody who is having trouble adjusting or going through some agitation.
Ladies, thank you so much for that detailed overview of memory care. And I want to switch gears a little bit. Mary, what happens when a resident's needs change, requiring additional support due to a health decline? Is there a process in place to communicate with family members?
Thank you, Angelique. I think just kind of backing up a little bit, when someone comes to assisted living and assessment is completed, that assessment then determines, what does that person need, in that living environment, and how is the assisted living going to support that person? So it is developed as what's called a service plan or a care plan sometimes. With that, if someone has a change in condition, in the clinical term, a change of condition is usually at least 2-week time frame. So it's not just one day they're this way and the next day they're that way. So it would be a permanent change. That then is communicated from the clinical team to the family, to the physician, and then it's followed up and kind of a meeting is held and said, what do you need to put in place to support this change for this person? Is it a medical change? Is it, more of an emotional change, a cognitive change where there's different disciplines then can get involved in supporting that? At that point, then it's communicating with the family and, it's partnering. It's a partnership. It's a partnership with the family. They know, their person best, and we're working together as what is the best thing for that resident. I don't know, Brenda, you want to add a couple things to that?
Sure, thank you. And like Mary said, there's so much with, as a loved one declines is that communication. And I can't emphasize communication enough because it's a two-way partnership with our families, because you may have information about your loved one that we don't have and that we don't know anything about. So when we see a behavior, it may not look normal to us, but to you, it's like, no, this is why this behavior is in place. So that communication with you all as, a loved one is declining or you're starting to see that change. Obviously today compared to 2 years ago, how many of you participated in Zoom calls? Probably not many of you even had heard of Zoom, so now there's a lot of, family members who may not have seen their loved ones for a year or two because of, living across the country. Now it's like when they're seeing their loved one, they're able to see that decline and they're able to go, this isn't normal. And these are the kind of thing, we're looking for now in healthcare. It really, technology has really changed who we are and how we do what we do every day now, because we're able to have you engaged more with us, with the residents in our communities.
Great, thanks for those thorough responses. So can you share with our audience the benefit of a move to an assisted living community versus staying at home with supported services like a caregiver? Kiersten?
Sure. I think one of the things that we've talked about so many times each month as we've met together is that nothing is one size fits all, right? You know, you need to take a very thoughtful approach with your care team, whether that is your power of attorney and that's a friend or that's a family member. We've talked about geriatric care managers before. So these people who you've chosen to have in your life to give input in times exactly like this, you know, what are the pros and cons of moving at all, and then looking specifically at a retirement community that has an assisted living level of care. So one of the things I would say that is probably the biggest tipping of the scales, right? When you're saying, I could just stay put in my home and bring in care. And we've talked about this before as well. So if you do that, is your house modified? You know, is every one level living where your bedroom and everything is on the first floor? And if so, that checks a big box, but that's one of the things we talk about. Then we talk about your whole care team. You know, if you bring a caregiver in, you are bringing in somebody who's maybe a companion or maybe they're a CNA and they can help you with some of your activities of daily living, but that is it. So they are not a housekeeper. They are not going to do your laundry for you. If they are only a companion, then they are not qualified to help you with any of those more activity of daily living needs like toileting or showering. So I think, you know, we've talked about that before. When you're looking at an assisted living model, you're actually getting a whole care team. So we've talked about getting a social worker, a dietitian, a director of nursing, an administrator, the CNAs and the LPNs, all these nursing team members who are caring for you. So it's really not an apples to apples comparison when you're saying I can stay at home and just bring in a caregiver, or I can move to an assisted living and have an entire care team. So that's one thing I would think about. And then we've also talked before about neurocognitive change. So at the time that we're not just talking about physical limitations, maybe there's been a stroke and there's some weakness, but cognitively, we're really able to direct our own care still. At the time that you're caring for a loved one who has had changes that they're not safe in their current setting, then we are really looking at a move, because we're saying, you know what, in addition to all these other factors, we need possibly a secured neighborhood, or we need that increased staffing ratio so that someone is consistently checking in on my loved one. So those are some of the reasons, you know, physical safety, the environment, you know, trip hazards, having things all on one floor, and then of course, an entire care team.
I guess you didn't leave anything for me.
Oh, and, all right, I think, yeah.
So the only thing I would say, you know, comparing to being in a smaller assisted living like JK House of Grace and being at home with your needs, if you want to provide a caregiver that will help you there at home, it's probably, she can go up to maybe 3-4 hours, maximum 5 hours, although some people, they can afford having that longer hours, but you're gonna look at the financial situation here. It is more costly to have someone at home with you 24/7 as a caregiver who will not be able to provide the services that an assisted living can provide for your loved one. And that, I would say, that's the main thing that I would say about, in addition to what she just said. So cost effective, it will be better to be in an assisted living than having a private duty caregiver at home. Although, you know, the state of Maryland, I read one point that it says that up to 5 hours, the person can have caregivers at home for just basic needs that the loved one can get from someone from outside. I'm talking about caregiver from outside, not the caregiver at home herself. But in an assisted living, he can get whatever he wants based on what we provide, the intimacy of care. And again, I want to add something about what Kiersten said. The intimacy and the structure of the facility, it helps a lot in providing the care you need for your loved one.
Would anybody else like to add? If not, I'll move on to the next question. I know we briefly touched on this during the first question when defining assisted living, but I'd like to go in a little bit more detail. So Brenda, Are there additional health services available on site? And if so, are there fees associated with these services?
Sure. So thank you, Angelique. So I'm gonna start by saying location, 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 because your location really matters as to what kind of additional services may be available on, for our campus here in Rockville. We have our own physician group practice on site. I'm gonna say, I'm pretty sure Maria doesn't have on-site physicians that are they're part of her organization. So every organization is going to have a little bit of a different milieu as to what that menu looks like. Podiatry on site, having, those kind of things, having the eye doctor on site. Do they come on site? Being a larger facility, we're able to be an organization, we're able to bring those onto site so that you're not having to leave. And especially with those who are in memory care, do you really want to be taking them out and cause increased confusion because now you've moved them from point A to point B and it's like, what's going on? So being able to offer those, every organization is going to have a little bit different. And again, you have to look at them as an individual. It's like, what are my needs? So when you're looking for those are great questions to ask.
Brenda, thank you. I think, the physician service is a good point, as a large campus, what you have over there, Charles Lee Smith, for Kensington, physicians that actually come on site. So it's a little bit different model, but then I think most assisted livings, if somebody needs an x-ray, if somebody needs blood drawn, dental services, dietary services, there's a dietitian, a registered dietitian. Part of that role is also evaluating and making sure that those new menus are nutritional for the residents. X-rays, the psychological services, and also like rehabilitation services, physical therapy, occupational and speech therapy. That's a great program to have on a campus, when you're looking at safety with walking and extending and continuing to have somebody continue to walk. Like our property sits on 8.5 acres. We have a lot of walkers. The outdoor walking around the campus is very, very popular. So, it's programs and exercise programs with our therapy department to keep the strength for those residents. And I think it's kind of like Brenda said, it's you want to have services come on site to support those residents that may need that. With that said, everybody can still go to their own services and to their own doctor in their community. If they want to go to, psychological services, they can continue to do those. So it doesn't prevent anybody from continuing to kind of have their own services outside of the campus. So just, a note on that.
Mary, just to kind of add another aspect to this, again, I kind of talked about Zoom before. Now practices are actually, you're able to do Zoom calls with physician practices, so you may not necessarily have to go out, or, you're able to stay in your apartment and have those services brought right to you.
Yeah, I don't think there's anything to add on that. I think when you're part of a large community, especially if there is a large independent living population, you likely have already contracted and developed relationships with many, many professionals. So podiatry, dermatology, they're all coming on site. It's attractive for them. You've got hundreds of residents on a campus. So that is a benefit, to looking at for example, a CCRC model where you're going to have all of these providers coming to the campus like Brenda shared.
And I think, I'm sorry to interrupt. I think it's also in a smaller facility, we do have the same system that you have it in a larger facility. And with COVID changes now, with the telehealth and the Zoom calls with the doctors, that makes the doctor now is on site for us. So on top, except for the pediatrist, of course, he has to be available for us, and they come. We kind of like provide, or we have partnership, or we have networking with services like X-ray, echograms, Dopplers. They all come to our small home and they do the services there at home. We do PT, OT, and speech therapy at home too. So basically like similar, but in a smaller community.
Great. Well, the next question is, what kind of training do staff members receive at assisted living facilities? And is there a specialized training for staff when caring for people with memory impairment? Maria, if you could start us off.
Thank you. Yeah, the kind of training we do in a smaller facility, actually before we even hire them, they have to come up with their MedTech, which is Medication Technician Administration, certificate. They have to come with their CPR and first aid. These are things that it's a must for them to come with. And of course, you know, the training, we teach them why it's important for them to come and have them ready. Now, on the side training, we do training about the end of life training, and all of the training, by the way, we do, it's a must, it's a policy and regulation from the state of Maryland. So when the surveyor come, they will ask us to show and present what kind of training and how often those training are done for them. It's not like, you know, you just need to do the training for them. And in our facility, I go with the training on daily basis, because the need of the resident, it changes from day to day. Today, he's able to eat on his own and feed himself. Tomorrow, he's not able to eat, and he needs to know more about the caregivers I'm talking about. They need to know more about pureed food, how to prepare, and what kind of pureed food we need to do. Today, this person is on thin liquid. Tomorrow, he need a thickener in his liquid, and what kind of thickener we have. These are the ongoing training that I do there, and because I'm the nurse there, and it's sometimes, you know, it's a blessing to have a nurse who owns the facility too and work in the facility, not just like hired to be in the facility on certain days. So there are training about end of life. We do training about the cognitive impairment. We do the training on activities of daily living. You know, all of these are written for us, and we have to do it. And we need to certify those caregivers and check their performance evaluation for them. Like, are they doing what we are training for? You know what I mean? So these are the training, or part of the training. I want to give a chance to someone else to add to those trainings so we can divide the talk here.
Yeah, I think that's a great introduction, Maria. Similar to what I was saying earlier about assisted living being a regulated level of care. There are certain trainings that all of the models represented on this call, we are all doing trainings with our staff. So infection control, right? And everything we went through with the pandemic. I mean, there's certain trainings that are regulated. Every year, all the staff are getting it. So that's kind of your first layer. And then each community is going to do their own thing additionally. So for example, at Ingleside, our staff that are working in our memory support neighborhoods, they receive the certified dementia practitioner training. So that's a specific coursework and credentialing to be able to care specifically for individuals with neurocognitive change. And then Ingleside also has our own well-being model. So that helps each of our staff understand our approach to engagement, to autonomy, to caring for that resident in a respectful way that highlights what they enjoy doing and how they want to feel purposeful in their lives. So kind of additional layers to what's that base layer of what's required.
I don't know if the audience see if I want to show something about what is the most important training that I do there in the facility. So I'm sorry. It's like I do those, and they are in our facility on the wall all the time. It's how to approach someone with dementia. That's because we are dealing with the difficult cases in the facility, and it is important for them to know how we approach them by sometimes I use a simulation things that are in front of the caregivers and the residents to show, did I do it right? Was it right or wrong? And that will give them more training, like hands-on training with life simulation.
Brenda, did you want to add anything else?
was gonna say, I think Kiersten kind of covered all the, like you said, we're all regulated. There are certain requirements that every associate in our organizations has to be trained on. So when the state surveyors do walk in, they will ask for those documents. Some of those specialty things that we do here at Charles E. Smith, I mentioned it earlier, is BCAT, which is the Behavioral Cognitive Assessment. And it is specifically for memory care and enriching, the enrichment of brain health, especially with our cognitively declining residents. We want to make sure that all of our associates, actually 100% of our associates across our campus have been trained in it, but we really emphasize it in our memory care units and in the assisted living, as so that the housekeeper that is going in, that is cleaning the room, if she's starting to see that something is different in that room, that someone is all of a sudden Mary didn't used to keep, Mary, I apologize if there's a Mary on the call, I'm not talking about you specifically. But if someone if somebody goes into Mary's room and finds that, Mary's starting to collect things and Mary didn't used to do that, that even a housekeeper can pick those kind of things up and tell someone, because it's starting to see someone decline, or, her clothes are dirty and she was always meticulous, starting to pick those things up and being able to talk about those. So there's a lot of education that goes along with these different programs that we offer in assisted living.
Brenda, I just wanted to follow up on your BCAT. The BCAT tool is a great tool, and that is also part of kind of the initial assessment that is done to kind of determine where somebody's baseline is cognitively, which is a really good way to start. The last thing I just want to mention is, hands-on approach to training for memory care or cognitive impairment is so key. And, there's a lot of specialists, and someone like Teepa Snow, she's a education specialist with dementia, hiring someone like that, bringing them in to train the staff also gives a different perspective. And that's always a nice tool to use for the team. Make sure that, it approaches everything. So when dealing with somebody with memory care. So thank you.
And thank you. So it sounds like there's a lot of thought and training and investment that goes into your staff to make sure that they can safely care for the residents in each of your communities. So Mary, can you tell us a little bit about the lifestyle and leisure programs to engage residents in assisted living communities? And does this approach differ for residents with memory impairment?
I think I love talking about this topic, so thanks for that. But I'd like to kind of share that a resident's life does not end when they move into assisted living or memory care. And I think, just personally, I've cared for both parents who live here at Kensington Park with me. My mom was end-stage dementia. So I know firsthand how that is. But I think, engagement for our community, programming is so key. And in the memory care area, it's more of a pocket programming that we use, where it's small groups that are going on simultaneously. So, you're just not going to have one event geared to everybody, because everybody is not the same. So, it's separated out. But, I will tell you, there's families that, and I'm sure all of you experienced that, Brenda and everybody else, that, well, my mom would never do that. And there she is, she's in the music class or she's in the art class. And, you have a different opportunity to explore things that are presented to you by the activities programming. I can tell you for our community, we have a photography club, and just they, enter their pictures in the Montgomery County Fair every year, and we have winners. So it's part of the entire community. It's just not, what you might think of as bingo and these kinds of things. You would try and look at that individual person. Good example is somebody who's a minister. This week we've had them present an Ash Wednesday service for everybody else. So you're engaging those to community life like they are used to doing. And I would say that's probably the biggest thing, and into the local community. For us, we get involved in the Labor Day parade with the rest of Kensington and those kinds of things, which, you know, they volunteer across campus. I'm sure Brenda and Kiersten have huge volunteer programs where they are as well. So it's very, very important. Thank you, Brenda, or whoever else.
Yeah, Brenda, or anybody else from the panel like to add?
Sure. So this is kind of my wheelhouse, being a former certified therapeutic rec specialist is where I started out my career. So, you know, activities, and then now being the vice president of operations. So I kind of have a little bit of a soft spot for life and leisure in our campus. So I really kind of push those activities, you know, even during the pandemic that, you know, that we've had to kind of pull back, you know, we pull back and start. The type of things, and as Mary said, it's like, what is the resident interested in, and can they bring, you know, having those conversations and being able to talk about, you know, what they did, you know, where they traveled. I'm looking at some of the, you know, the back pictures here, you know, it's like travel logs. What did they do? And being able to talk about those kind of things, you know, and I kind of laughed when you said bingo, Mary, because it's like, heaven forbid you ever take bingo away from any of our organizations, there would probably be a mutiny, because it is one of those things, you know, and I'm kind of, you know, my own mother, who we just recently moved into independent living, is now going to bingo. And I laughed when she told me that, because it's like, okay, you know, here we go, you know, what's in it. So all those kind of things, whatever your interests are in, you know, our communities, they're doing trips. We had our AL went to Hershey the other week on a bus trip up to Hershey Park, and they did the tour of the area. So there's lots of things, you know, it's just not coming in, and it's just not playing bingo. There's a lot out there to do, and the life and leisure folks in all of our organizations, big or small, are just, you know, very engaging, and it's great to see.
Yeah, I think the only thing I would add to that is that when you look at a large community, this would be, I think there's probably quite a few reasons to look at a continuing care retirement community or a life plan community. But one of the big ones I would say, and I see again and again, is that if your physical needs are requiring you to come in at an assisted living level of care, but cognitively you identify completely independently, then you're able to associate and participate in all of what we offer in our independent living communities. So for example, at Ingleside at Rock Creek, there are 9 independent living buildings. And so they each, you know, have a different service or amenity on the first floor, a fitness center, and a salon and spa, and the cultural arts center. And we have 25 plus committees on campus. So, you know, if your career was in the foreign service and you want to hang out with people in a similar past season, and you're saying, you know what, I gravitate towards talking about finance, I want to be on the finance committee. I think that's one of the beauties of being in a campus that has this large independent living population, is that your care needs might dictate that you reside in assisted living. And certainly there are programs that are led right there in assisted living, but you also have all of the services and amenities of the rest of the campus open to you.
With all respect to all what you said, I'm going to summarize them very quickly, and I will give 2 examples of what we did in a smaller facility like ours. So family and community engagement is very important, by the way. If you get the family to engage in the activities, it helps the resident get the relationship back with his family and with his friends. And the community activity or community involvement, I do have a gentleman who was an antique car racer, and he ended up having vascular dementia, and he lost his limb. So one of the things that he doesn't have family. Most of my residents their family is out of state or out of the country, actually. Family is not in the country even. So I got a family member that I used to take care of. Her mom passed away, but she's still as active member to do activities with us. So she arranged with us and the community at Leisure World to bring all the antique cars to come and tour the area of where we live in Silver Spring area. And they drove the road over than 25 antique cars came on a Saturday and Sunday to do that activity for that gentleman. He sat outside and they all came and just waved for him. This is the community involvement. This is where I think as a smaller facility, a smaller assisted living, we can get the community to be more involved and more proactive with us. The painting and drawing, you know, I think all of you or all of us, we can do it at certain different levels, whether it's a small community independent living or a larger nursing home. Exercising, dancing, and outside group trips. We can do the puzzle cards and question and answers for different levels of dementia or different level of cognitive impairment. The religious holidays, as Mary, I believe, or Brenda mentioned it, you know, it's like the Ash Wednesday we did, and soon we are doing the Jewish holiday with them. And we do the meals preparation. Some of them, they're just being housewives. So they like to prepare meal. They will say, we want to do that and we want to do that. We can ask them, and what do you want us to cook today? And we will cook that meal for them. See, that's different from a larger facility. Larger facility, they have certain menu to follow and a kitchen to do the work. In ours, the kitchen is there for them to get an access to. So they can prepare with us the meal that they want. We do the movie day and we do the bingo trips and music therapy. I think Mary mentioned something about music therapy and how important it is for them. Pet therapy. I didn't hear anything about pet therapy, that the pet activity and the visit with the pets, whether it's a goat, chicken, duck, we have like now the farm come to you. And there's a farm, a small farm that they can build it in front of the facility there for you on the outside. And then the residents can go touch the horse or the miniature donkeys or those ducks or little animals. Mostly that I found that they're interested in is the dog therapy, you know, when the pet dog as a dog come and visit with them. So these are all important for all levels of dementia. You can say like he's cognitively impaired, totally impaired, but when they see the dog, immediately they reach out for that dog and they want to play with that dog. So thank you for asking that question.
Yeah, these all sound like wonderful programs. But as Brenda did make a brief mention of the pandemic, so I do want to ask how you all modified your programming due to COVID.
So I'll start with that one. And wow, what the pandemic really kind of set all of us back on our heels. You know, as mentioned earlier, being a licensed residents, we had to stop all visitors from coming in. You know, so we really did see a kind of a decline in, I'm going to say, in our residents because they didn't have that access to their family members. They didn't, you know, they weren't coming out of the rooms. We didn't know what to do with them. So a lot of programming went to in-room programming, more one-on-one. Now, 2 years later, we have kind of come, you know, we're coming back out of that shell shock of being pulled back so much, that doing small group activities, being able to open the dining rooms back up again, being able to have visitors coming back in, because we're open now to visitation and allowing folks to come back in, allowing groups to come in, you know, small groups, those kind of things. You know, we're not back to the large 100 people in a room and those kind of things yet, but, you know, being able to socially distance and still being able to have that personal, you know, touching, you know, is definitely back in place. Our memory care unit, you know, those folks, because it's really difficult for them. One, they didn't want to keep masks on in that unit, but being able to have activities for them that they are able to participate in a daily basis to their liking. So it really, we went from being, you can't do anything, it has to be one-on-one, to being able to now have those open groups again and having the music groups and everybody coming back in. So.
Yeah, Brenda, and I mean, you know, you and I, if you've been in the field for a long time, like that was the worst disaster that could ever happen. And, you know, I think as Brenda mentioned, we were all working through it. Nobody knew what it was and how to go through it. And you kind of just worked through it. A lot of it was just kind of common sense. I think the big piece in all of it was masking was the key. And once we figured out that, then you were able to kind of open up a little bit more with the physical distance and those kinds of things. I mean, the goal always was to try and keep the connection with the family and the resident for us. And how did that happen? I mean, I applaud the activities team. They were the superstars along with the care team in that whole situation. They were the ones that connected and continued to make those connections, at least for the first part of it, until you kind of knew how to maneuver it, and you could have outdoor visits and different types of things. And then, once PPE was there, you can dress people up in PPE. And I think, unlike the hospital side of it too, we're here to care for, seniors and their families, and that is, kind of our motto. So it was bringing those two together, end of life, hospice care, and those types of things. You're dressing people up in full PPE so they can have that visit, connection that, was missing because of the pandemic, and do it in a very safe way. But yeah, much different place. Vaccination, I'm sure everybody cried when we had vaccination come through. And, I'm proud of our team. We're a fully vaccinated and boosted community with 240 staff members and 180 residents. And we're at the place now where, because of that, the residents in the next couple of weeks will be coming off with masks in the common areas because everybody's at a boosted place. Now the visitors will be a different situation, but we're definitely much better off than where we've been. So yes. Kiersten, I don't know your clinical piece, if you want to add in something else.
Yeah, no, I think you and Brenda, with all of your knowledge and experience, and the nursing home administrator component, I think you covered it. I would just say in a short summary, a lot of one-on-one programs to begin with. I think we all worked through that. And then a silver lining is that we are all now so much more connected virtually. I know at our 3 communities, we were able to do virtual presentations and lectures that we never thought about doing that before. I mean, we have a community in DC, Maryland, and Virginia. We'd never all joined in together on the same Zoom call. We didn't do that before the pandemic. So I think, as tough as it was to pivot to one-on-one programming and using virtual platforms, there ended up being a silver lining, and that we all ended up being more connected.
Wonderful. Thank you so much. And ladies, thank you so much for painting the picture of care and services available at assisted living communities and those requiring memory support. I want to be, cognizant on time, so I'll ask this really quick, and I'll start with Kiersten. When should one explore the option of moving into an assisted living community, and how would you guide them through this process?
Yeah, I think we can go quickly on this question because we kind of already touched on it. Rely on those people that you've chosen to have in your life, your powers of attorney, your family, those chosen friends. If you don't have some of those positions, reach out to Angelique or myself. We can refer you to geriatric care managers, or Catherine, I think probably still has those resources from one of our very first sessions. But rely on other people. Don't try to go at this by yourself. Just the fact that you're on a call like this to gather information, that's the first step. Gather information. I think I saw one question in the chat about, assessments. That's a great place to start. Talk to your primary care provider. If there is neurocognitive change, they can do a cognitive assessment and help give you a concrete idea of, in this moment, this snapshot in time, what is the baseline of your loved one or your cognitive status? Do you need to be in a different care environment? So don't go at it alone. There's a ton of resources in this area, especially for learning, for figuring out what care needs you have. And then I would say start to schedule your tours. So looking at a couple different models is wonderful. I think earlier I spoke about our model, the life plan model, but to Maria's point, if you have a loved one who has some very unique needs that you feel like, I want them to be in a group home setting where they're getting care in an individualized way with only a handful of other residents, that's a very specific, unique model. If you know that about your loved one, or if that's what a geriatric care manager is recommending, you want to look at a couple different models. So I would absolutely say, look at a big life plan community, maybe look at a standalone assisted living, look at a group home. And then within that, don't overwhelm yourself. You've got a couple models, that's all you need to look at. You don't have to look at 10 or 20 different communities. Very similar to helping your child look at colleges. You know, you look at a state school, look at a small private school, and you have a sense of what you want to do.
Most of all, educate the public, because most of them, they don't know what's dementia, what is the stages, what are the different levels of dementia. So education to the public is very important before they even know what other options they have in front of them. Most of the families, they live with their loved one and they don't know that this person, he keep repeating, asking the same question. They don't know that this is part of dementia. They think it's part of normal life, that he's just end up asking those questions. So in addition, what you just said, I agree with all what you said. It's very important for them to know their resources.
Would anybody else like to add?
I think I'd just like to add to really think about what is it that's important to that person moving in and to the family. There's a number of different tools out there of what to look for in assisted living. There's some good questions that guide you through questions to ask when you're touring communities. You know, location is key. You know, how often you're visiting, is it far away? But then, you know, it's really all about how you feel when you walk in that community. And most people will say it's just a feeling, you know, you can tell how it feels when they come in. And so it's kind of a combination of those. The state of Maryland does require all of us to have a uniform disclosure statement that helps to compare, you know, Maria versus me versus Kiersten versus Brenda, you know. So how do you look across the spectrum and say, well, how does that make sense? They're all so different. So that's a helpful tool as well. And I think the time to move into assisted living is, you know, your world gets a little bit smaller if you're not able to get out and drive to go see your friends, you're not able to go to church, you're not able to go to the clubs that you used to go to. And you know, again, your life doesn't end when you come into an assisted living or independent living. You know, it's just you have the support there to help you continue to live.
Thank you. I did want to, I guess part of the question, I just want to make sure it's a yes, no question. Is there usually an assessment required before you can even move in? I guess I wasn't sure if Kiersten answered that. For assisted living.
There is. I'm sorry if I missed that part. Yeah, there's for whatever jurisdiction you're in, Maryland, DC, Virginia, there's a universal assessment that each one of us will require that same physician. It starts with your primary care provider.
Okay. So great. And last but not least, I know a lot of people are always interested in the cost. How are the monthly service fees calculated, and what are usually included among those services? And also, are there resources to help cover the cost of care? You know, some people wonder, is this something my long-term care insurance would cover, or et cetera? So if you could delve into the financial aspect, please. Beginning with Brenda.
Sure. So every one of our organizations has a different fee schedule. I don't think you could look at any one of us and go level 1 here, level 2, level 3. As it's raining all day and now it wants to rain. So I apologize. So there are, you know, there's different calculations, and you're going to have to ask the organization what level did I level? If you remember in the beginning, Kiersten was talking about level 1, 2, and 3, or Mary, I believe one of you had talked about those. What are your level 1 fees, and are there add-on fees to that? Is it a menu kind of fee for service, or is it an all-inclusive fee? So every organization is going to be a little bit different. You're going to have to ask those questions when you go in. Long-term care insurance, there are, you know, if you have a long-term care policy, does it pay for part of your AL? There are some out there that do help pay for assisted living. But again, you need to look at your policy. How much does it pay per day? What is that pay? Because you're renting, for us, you're renting an apartment. You're renting a room. So there are fees that go along with that. And, you know, again, it's a menu. What is it that you want? And you can select from that. Mary, do you have?
Yeah, no, I think that's a good recap, Brenda says it's all different. Like I know previously, I worked for Marriott Senior Living years ago when I opened Maplewood Park Place, and they group their service package differently. It's in kind of an all one thing, and you get this so much, and then there's a fee for it. Here at Kensington Park, you pay your base rent for your apartment, and then you're looking at medication and care levels, and the assessment for that is part of the medication, and the care level is determined when that is an assessment is done. So they answer then what is included in that, your laundry, your meals, your services, and then basically your separate individual service plan, your activity programs. If they're going to the local theater, or they're going somewhere outside of that, that is a cost, just like what you would pay for a ticket if you were going to the theater on your own. So, those kinds of things. There's salon services and barbershop services on site. Those things are separate than included in those monthly fees. We talked earlier about like the doctor visits and those kinds of things. Doctors, podiatry, all of that is under Medicare Part B. If you have Kaiser, that's a little bit different situation. Then you fall into your Kaiser plan. And then, also there's other options with that as well. So, but yes, long-term care insurance has come a long way, and it does depend on your plan, but they can be very good financial resources for assisted living.
Yeah, I can just answer for our community specifically. Ingleside has an all-inclusive fee structure. So for our assisted living level of care, we do not tease out room and board or medication management or meals or programming. And I think, Catherine, you had wanted us maybe if possible to share exact fees. I think that's helpful, especially as we do talk about long-term care insurance and how much it's able to cover. So for example, at Ingleside at Rock Creek, in our assisted living, traditional assisted living, not a memory support model, it's just shy of $12,000 a month. And again, that's everything. So that's an all-inclusive rate, and that would be for one individual in a 1-bedroom, 1-bath apartment.
Same in our JK House of Grace assisted living facility. It's a home environment. Again, we say it's all inclusive, but we will say except for. We are not going to, like if the family asks for a daycare, this is an addition that they have to take care of a daycare if they want their loved one to go to a daycare. Pharmacy review, this is something that the pharmacy has to come and do, and that's their state, regulation. There's the blood work. It's true that their insurance pays for it, but since the pandemic, the blood work technicians, they have to start charging for driving fees, like, to come to your facility. So that's something the family has to be aware of, that there will be an extra charge for that. There is like psych doctor who comes and visit for certain psych conditions. This psych doctor, they doesn't charge their insurance, no matter what, if it's a Medicare, Kaiser, or whatever, it has to be a private pay. So the family has to be aware of those extra charges for this special psych doctor. There are other psych doctors that they go after the insurance of the person. The other
Maria,
I'm sorry.
Sorry. If so we get, I guess, the idea that it varies. I just want to make sure we clarify. So Kiersten mentioned, for, I guess, a model, an all-inclusive at a big place, it could be like about $12,000 a month, not including memory care. I guess I wonder if you and some of the others could just mention a ballpark, to give an idea for people who are evaluating, can I afford assisted living? It could be a ballpark range. I think that's appreciated.
It is different. Again, it's according to the level of care and how much on hand or per hand care that the nurse herself has to be available for the person, and how many caregivers has to be available for this person. As you know, we are taking care of the very difficult cases. So we can start at $225 a day, and it can go up to $350, sometimes to $400. It depends. So as I said, because some of the families actually, and I learned it from my families that they come to me through their geriatric care managers. They will come with the price that I put there for them. And then they will say, I would like to have my private duty caregiver to come on top of what you're charging. That's when I will say, you know, if you want to do that, I'm happy with it. If you don't want to do that, we will just provide that extra person, because as you know, the private duty caregivers, they have certain time to come, and they cannot just come for 1 hour. It has to be certain level of hours. So I would say that time where we can provide the extra help, we will charge for that, the extra. And we will just get that person at certain time. So yes.
Thank you so much. And the
You're
only
welcome.
before, so we need to, unfortunately, we're running out of time, so we need to get to Q&A, but I did just want to clarify for the record, my understanding from you all, right, is that the important takeaway is that Medicare doesn't cover most of assisted living, right? Unlike nursing. That's a confusion sometimes, right?
Correct.
Okay.
Medicare, they don't pay for assisted living or nursing home. They pay for the services happen in there, for doctor visit, for PT,
Exactly. Yep.
all of these.
Just want to make
But
sure that
the
everyone
one that-
understands.
Yeah, the one they need to understand is Medicaid assistant that will pay for assisted living if the assisted living is licensed to have it.
Yep, great. Thank you for that point, Maria. Yeah, so Medicare, no, except for doctor visits and that stuff, but Medicaid, yes. So something to keep in mind. And so we did get a few questions from the audience, so thank you for those. And the first one, how do you handle couples when one person needs memory support or care, and the other person does not need memory care?
So I'd be happy to answer that. We've had several couples, and it's really kind of based on that individual couple and what their needs are. Now, I've had situations where, you know, the wife needed memory care and the husband did not. He was very independent, alert and oriented, was adamant about living with that person in that environment. We were able to accommodate him to the point where he did spend the night and stay with her, but during the day, you know, there's 3 buildings on this campus, so it's a large campus. He was engaged in independent living activities or assisted living activities, going to the happy hours throughout campus. And, you know, while we cautioned against that, just because living in an environment with cognitive impaired residents for somebody that may be alert and already could be very challenging at times for them, just emotionally, and having to continue to have that engagement with also your loved one for that 24/7 period of time. So we set up a system to kind of give him breaks, and so he had mental stimulation too. And there's been other times where, you know, at some point during the care, you know, couples have to separate just because the care needs for those individuals are impacted by the 2 of them being together. And then it's setting up in 2 different and living environments, and then communication and engagement, and have that be part of their routine life so they don't lose that connection. And, you know, I see Brenda shaking her head, so I'm sure she's been through some of these challenges as well. But it's really like, what is the best thing for the couple, and then looking at each individual and is, you know, trying to work through that. And it's not easy all the time.
Mary, I completely agree with you. And we've had similar situations where, you know, you really need a high level of care for one member of the couple, and the other one is independent, but, you know, wanting to be at least close enough where they, you know, one may be in memory care and one may be in the assisted living, or for us, because some of our residents are independent living is actually connected, can still be in independent living. So it really is an individual, you know, we look at everybody as an individual and we'll make those recommendations on here's really the best setting. And, you know, sometimes couples don't want to be in the same, you know, we can have folks in the apartment together. Unfortunately, sometimes they don't want to be in the apartment together. You know, they want that separation so that they, you know, they can be the family member and not the caretaker. Because a lot of times if they're in the apartment together with someone who requires a lot of assistance, they then they still remain that caretaker, and that's difficult for them.
Okay, great. And well, yeah, thank you for the insights on it. It's somewhat related note, and we might have already talked about this a little bit, but basically if you are what steps should we follow when choosing assisted living care for our spouses? How do we choose? And I do hope that, and I will be sending around the questions that were asked during this panel, some of which you could also think about as a guide when you're evaluating assisted living facilities. But does anyone else have some thoughts on this, choosing assisted living care for your spouses?
You know, for me, it's just take the time, and I think Mary mentioned, and I think also Kiersten and Marie, go out and see, you know, take the time now before you need it. You know, if you're in that, like, oh my gosh, I need to get my family member into, or my spouse into a place, it's probably already too late. So go out and look now so that you're, you know, get to know us before you need us is really kind of, you know, our motto. It's like, because you really do want to, it's like, know who we are, each one of us, because something could change. And it's like, well, I really thought that I wanted a bigger, you know, organization, but you know what, maybe I really want the smaller home-like setting. So it definitely changes.
The only thing I would add to that, because I think Mary already touched on specific interests, and we've talked so much about models of and types of assisted living. When an adult child is looking for their parent, this is the only part that I would say differs from when a spouse is looking for their partner, is that if you are looking at moving into independent living and you're saying, I want to be on the same campus as them, then you're looking at a specific type of model to say, I want to move into independent living so that they can be in assisted living and I can just walk across campus to see them. That is a question an adult child would not have to ask.
Right.
Indeed.
So the
Someone
answer-
also want.
I want to add one more thing is you have to ask the questions you want, and you ask for references. You don't just visit. You say, okay, can you provide me with some references of families that you served? I would like to ask the questions myself. They have the chance also to interview your caregivers. I mean, I have several families, they want to interview my caregivers and ask them how many years you've been here, what kind of work you do. These are questions that the family have to be proactive before they decide on which facility they want to go with.
Thank you so much. That is such a great point. You know, don't just take the facilities at their word. Talk to some of the residents and their families to get that, you know, third-party opinion and assessment. Now, what are the pluses and minuses of going from independent living in a CCRC to assisted living versus staying in your home a little longer and then going from your single family home to assisted living? Like, are there issues of quality, availability? Like, I guess someone's weighing, you know, is it better to try to go to independent living first, then assisted living, or their advantage, or is it just as well to wait until you need more assisted living level of care?
Catherine, I can answer, and then I know Mary and Brenda also probably have perspective on this. One thing I would just say at the outset is finances. Independent living, like we talked about earlier, is largely a social model. So a benefit to being an independent living first is that when you move to assisted living, if you do, you already have all your friends on campus. You've already been acquainted with the community. You're familiar. So that would certainly be a benefit, that continuum of care. But I don't think it's that easy. You need to look financially, talk to your financial advisor, because moving into a independent living level, maybe if you're limited on resources, might detract from what you have to spend at the time when you truly need a medical level of care. I will just answer for our community. I'm sure it's the same for other CCRC models. You have priority if you're in independent living. So if there is a concern, for example, I'll use Ingleside at Rock Creek. If you know I always have wanted to go to assisted living at Ingleside at Rock Creek, that's my plan. You probably wouldn't necessarily get into our community. It typically remains full, and it's only our independent living residents who come into our own assisted living. So that answers, I think, both parts of that question for us. We prioritize our independent living residents.
Mm-hmm.
Yeah, the only thing I would add to Kiersten is it's financial, the packaging of how it's financial setup. You know, it's you know, like I know for Maplewood and like some other CCRCs, you buy into it and then you have, you know, a lower cost assisted living for their skilled nursing and assisted living, if that is what you need at that time. So you really need to look at what the financial setup is, I think to Kristen's point. And I think then too, just kind of deciding, is it assisted living or independent living? It all just goes back to what do you need at that point in time? And what support do you need from, moving to another environment?
Yeah, actually, someone did ask about buy-ins. I guess one thing maybe I'm wondering if you bought into independent living, does that get transferred to assisted living and you like pay the difference, or how does that part work?
We're a rental type of situation. So I know for our independent living, it's a rental type of situation. And like Kiersten and Brenda, you have a priority to go into the assisted living and memory care. There's not another fee that is charged, to go into those other two communities at that point in time at all. So once you're kind of already here, you're here.
Yeah, and I'll add to that, Mary, that you can draw down on that entrance fee model at our community. So those resources that you bought into the community with are then available to you to spend to cover the cost of assisted living. So in that sense, it can feel like a health savings account, if you will, because you've tucked those resources away in the community to use for a higher level of care.
Okay. Sorry, Brenda.
That's okay. Here at Charles E. Smith, we're a rental community, so we do not have a buy-in.
All right, so I hope that answers the question of models. Yes, there are models with buy-in, and there are models without. Someone also asked about what kind of vetting occurs for healthcare providers that come on site, like the doctors and such that we were talking about earlier who visit.
Sure. So our main physician group that is here through Hearst Medical, they are credentialed through us. Any other physicians coming in, they would have to go through our credentialing before they would be allowed to come in and to see any of our residents. And that would go for any provider.
And also, we also ask for their, if they have liability insurance, if they have any other insurance too, before they come and practice or see our patient residents.
Great. And if a facility doesn't have skilled nursing, what are the plans for end of life care?
So different organizations, and I'll jump in on that, and they don't necessarily have to go to the skilled nursing side unless the family wants them to. A resident can remain in their apartment and have hospice come in. The different hospice organizations here in Montgomery County come into probably all of our organizations and can do it on site.
It's the same with the smaller facility. We just get either palliative care to manage the pain if it's a pain management, or end of life is hospice care. Yes.
Okay. And what are resources for independent evaluations of assisted living facilities?
Not quite sure what that question was.
I guess.
I think there's, there's like senior living associations and the National Center for Assisted Living. Those are outside organizations. If you're looking for separate resources from like the provider, you could turn to those types of things.
Mm-hmm.
Yeah, if that's the question, I wasn't sure if it was a medical assessment, Catherine, or if it's just a reputation assessment. I know for continuing care retirement communities, they can be accredited through a body. It's CARF is the accreditation. So that's a voluntary accreditation. You could look up if a community has pursued anything like that. If you're talking about medically, then start with your primary care provider to see if assisted living would be the right level of care.
And I guess someone commented, independent evaluators other than Medicare seem to be important when evaluating care, perhaps. And I think that's it. Does anyone have a last minute question? All right. Well, thank you so much to all of our very knowledgeable panelists. I think it's great for our participants to see the different models. Oh, one more quick question. What would be the advantage of having access to skilled nursing?
I thought that might be a follow-up question when we answered the other one. So I can answer this, and I think our two nursing home administrators can as well. And I think it's a different question than what was asked earlier about end of life care. Two different things. End of life care can happen in any setting. It could even happen in your home setting there in Chevy Chase. So you can bring in a hospice provider and receive those end of life services. I think something we might talk about in May, what does death with dignity look like? What does it look like to pass in your own home? So that's a totally different thing than skilled nursing. Skilled nursing is a highest regulated level of care where there's certain services that can be provided that may not be provided in assisted living level of care. And so if you are needing those skilled services, for example, I can list a few, and I know Brenda and Mary would know more, but maybe IV antibiotics, or in some jurisdictions, tube feeding, or if you have wounds, there's certain needs that you might have that you can receive that care in skilled nursing and not in an assisted living level of care.
Now, Kiersten, I think that's kind of what you hit on it. I think you should look at skilled nursing or nursing as a continuum of care, and based on what's happening. A good example sometimes is like Kiersten's talking about IV antibiotics, or for rehab. And if you have a situation where somebody needs more rehab than you will get in the assisted living one, they have the option to use their Medicare Part A, which is a whole different topic. But they then could use that, get rehab, get stronger, and then come back to their assisted living environment. So it can be used in those terms as well. I think the long-term idea of nursing home from years gone by, I don't, and Brenda, you've been more familiar with that lately than I have, is probably not at the same place, because you can do that with, end of life care and hospice and assisted living too. And it all goes back to having your advanced directives in place, which I'm sure Catherine's already had that as one of her topics, or soon to be.
I would, Mary, and I would agree. It's like the nursing home of old, where it's like, they were walkie-talkie, you were moving around, has definitely changed in the long-term care spectrum of our organization. They're much sicker. They're coming in there, when you're coming into the skilled nursing, which is also called SNF, you'll hear it called PAC, post-acute care, is a short stay. And it's your Medicare, or if you have another insurance that is paying, that's where you're going to use that. But it is really a short stay. And then it's getting you to that next level. What's the most appropriate level of care for you? And that's all of our organizations are here to help you with that and make sure that you get there.
Great. Yeah. So, and again, if you're interested in skilled nursing, I encourage you to come to our April 1st presentation. Thank you everyone for turning out. We really appreciate your interest. And I will say that I will send out the recording sometime next week, along with the contact panelist information. So, and also the registration link for the next program if you're interested. So thank you again, everyone. Have a great afternoon.
Thanks, everybody.
Thanks, everyone.
Bye-bye.